Hi, good afternoon, everyone, and welcome to Texas. I feel like I'm from MD Anderson, so I should welcome you all to the state of Texas. So this afternoon, we're going to have a wonderful symposium on overcoming obesity-associated risk with three amazing speakers. And what we'll do is we'll have one speaker at a time, and I'll introduce them as we go. And I'll ask you to hold your questions because we do have time after the educational session, about 15 minutes for Q&A and a really great interactive discussion. So thanks for that consideration. So we're going to start with Dr. Steve Hursting, who's at the University of North Carolina, and he's going to be speaking on breaking the obesity-breast cancer link, comparing diet, drug, and surgical approaches. Thank you.
Thank you, Dr. Brewster. It's a pleasure to be back in Texas. I spent 10 wonderful years here, and also an honor to be with you today to talk about strategies for breaking the obesity cancer link with a focus on breast cancer. It's particularly sort of exciting for me. We've got some new data on the weight loss drugs that everyone is hearing so much about. What are their effects in our cancer models? So I'll share some data at the end. I have no financial relationships to disclose, and we'll start with the evidence relating to the links between obesity and cancer in both animals and humans, with a focus on mechanisms. I'll spend most of the time on this question of how do we disrupt this obesity-cancer connection, and we'll compare diet versus drugs versus bariatric surgery. And we'll end with a bit of a discussion for the need for precision in this area. Certainly any of these interventions are heterogeneous in their effects. And so how do we best kind of predict and prescribe which approach might be best for whom is a question we need to begin to really focus on. Well, I'll start with the most sort of comprehensive synthesis of the evidence related to all things food, nutrition, physical activity, and cancer. And it's the American Institute for Cancer Research, World Cancer Research Fund expert report. I've been honored to be part of this since 2007. And one signal that's really gotten strong out of this process, and it's continuing, there's another effort underway here, is how important obesity is across many cancer types. In fact, the 2018 expert report, the most recent, identified 12 obesity-associated cancer types that were really strongly driven by this obesity epidemic across so many parts of the world. I was also part of a similar approach, actually a different approach, similar question, through the International Agency for Research on Cancer in Lyon, France. And this was, it ended up being the IARC Cancer Prevention Handbook 16 on body fatness and cancer. And the approach here was to look at obesity and cancer through the lens of the IARC carcinogenesis protocol. So for years, IARC's been looking at chemicals and their relationship to cancer risk. Well, does obesity fit in there? Is it in a sense a carcinogen? And the answer was kind of yes. Using like I said, a very different strategy, a very similar finding from the epidemiologic data as the AICR, WCRF data. The IARC effort found 13 obesity-driven cancer types. They added malignant melanoma to the other 12, and so good concordance in that regard. The team was also tasked with asking the question, is this reversible? If after many years of chronic obesity, can weight loss reverse the pro-cancer effects of the obesity? And what the conclusion of this was that there was insufficient evidence. Weight loss reverses the obesity-cancer connection. This question just hasn't been adequately addressed. And this is as of about 2017. There are a lot of efforts underway. I can't wait for Be Well, one of the large trials, really looking at this question. So we'll get some more information on this soon, but there's a gap in the literature regarding the reversibility of this obesity-cancer connection in the human literature. What about animals? I was part of the animal models team, and we found sufficient evidence that obesity promotes cancer really in the kind of the same cancer types as seen for human, obesity promotes those cancers. Now, a number of the studies, the sites were limited in terms of the evidence, but really the picture was very similar, animal to human, in terms of obesity as a risk factor for a number of these cancers. The other side of the coin was also assessed by this group, that there was a strong cancer preventive effect by preventing obesity in animals in an area called calorie restriction. A number of studies have been done, probably now upwards of 200 different studies in the literature across a variety of cancer types, and you could argue it's the most consistent, strongest anti-cancer effect of any intervention studied. So that's the other side of the coin. Preventing obesity prevents cancer in mouse models and rat models. But again, we were challenged with that question, what about the reversibility? Are there studies showing once you make mice or rats obese, can you reverse the pro-cancer effects of that obesity by weight loss or other means? And again, limited preclinical evidence that this can be done. Some more studies have come out in the last 5 years since the IARC effort, but still, this is an area with some need for further evidence. But I do think a clear message comes from both of these initiatives, that we as a cancer research community need to pivot from the question of whether obesity is a risk factor for many cancers. It certainly is, that's well established, to the question of what are we going to do about it? How can we reduce the impact of chronic obesity on cancer? And I was fortunate enough to get an R35 7 years ago, just ended this past July, and I miss it greatly. But it addresses several key unanswered questions for developing mechanism-based interventions to break these links. And I'll walk you through quickly some of those questions. The first is, what's the possible mechanism underlying the obesity-cancer link? This is an area we've been working on for most of the past decade, really. Really the bottom line is an interacting systemic metabolic alteration associated with obesity with adipose-derived factors and the pro-inflammatory, immune suppressive effects that result from those interactions. So starting on the left side here, a number of adipose-derived inflammatory factors are produced in a dysregulated adipose pool so that you see with obesity. So increased leptin, decreased adiponectin is sort of a hallmark of that. Increased cytokine production, typically a result of that. Trying to clean up all that lipid and sort of the lysis of adipose that's occurring, driving some of this. But that drives signals downstream of those cytokine receptors, such as JAK-STAT and NF-kappa B signaling. These signals interact then with systemic metabolic factors that are also altered in the obese state. This includes hyperinsulinemia, increased bioavailable IGF-1, and these growth factor signals through their receptors, IGF-1 receptor, insulin receptor, interactions with the epidermal growth factor receptor, for example, driving these metabolic changes, particularly down the mTOR pathway, PI3 kinase, AKT, mTOR activation, as well as RAS, MAP kinase signaling increased in response to the obese state. And these combine to drive proliferation, survival signals, decreased apoptotic, cell death regulatory mechanisms, increased angiogenesis. The other emerging piece to this is, in addition to these metabolic, epigenetic, transcriptional reprograms that are occurring in response, is in this inflammatory signaling, a role for the microbiome is emerging and probably largely contributing to inflammatory signals through obesity-induced changes in the microbiota. So these are the interacting kind of signals that are occurring in the obese state that are common across many cancers. And the other thing that's really emerged in the last couple of years is how immunosuppressive the obese state is in the tumor microenvironments. The tumor's growing in that growth factor-rich, inflammatory-rich environment and are really showing signs of immunosuppression. We'll talk more about that and ways to reverse that and what it takes to really reverse that. Question 2 really gets us into the heart of the matter. Does weight loss following chronic obesity reverse the pro-cancer effects of obesity? Again, we said that there's gaps in the literature on this. We found evidence that it might not be so easy. After a long period of obesity, there are persistent signals that seem to be, even if you've lost the weight, that are resulting from that chronic obesity. Now, if you do things like inhibit mTOR signaling with, that's Afinitor, RAD-01 was the original name for that when we did that work. So if you combine the weight loss with an mTOR inhibitor, with an anti-inflammatory agent, you can boost the weight loss effect. And again, it's probably not the weight itself, it's the ability to reprogram the metabolic and inflammatory state. So if you can boost that, you'll have more of an anti-cancer effect. It is reversible. But our evidence from our initial studies, and in both these cases, we did a low-fat diet, which is sort of a slow weight loss, kind of a modest degree of weight loss with that low-fat diet switch from a high-fat diet-induced obesity regimen, was not able to really, on its own, reverse the pro-cancer effects. So what's going on there? And what we found is that reversing the pro-cancer effects may require substantial metabolic reprogramming above and beyond what you can get by a little, 5%, 10% weight loss with a dietary, typical kind of lifestyle approach. We may need to fine-tune that a little bit. And consistent with that is a study we did with Carol Fabian and her team, a clinical study looking at calorie restriction in high-risk women at high risk for breast cancer in her cohort, and found that it took at least 10% weight loss in those women to get the sort of biomarker changes. We looked at a broad range of cancer-associated and metabolic biomarkers, and you really didn't move very many of those. I mean, leptin moves right away, so a little bit of weight loss will move leptin. Insulin moves fairly easily, but the broad spectrum really didn't move until we got women into the 10% and above weight loss, and really higher, better in that regard. So there seems to be something about this. The magnitude of the weight needs to be changed. What we don't also know is does the manner of weight loss, the speed of it, the way it's done, what influence that has. So lots of questions, at least at that point, when we're looking to be answered. So what interventions have been shown to sustain at least a 10% weight loss in women with obesity, and what is their impact on cancer? That's a key question. And what we know from the literature is that really bariatric surgery is the most consistent anti-cancer weight loss intervention. So the evidence is pretty clear on that. Calorie restriction in preclinical models works really well. Hard to do in people, and we'll talk more about that. And what about these incretin-based therapies that we're hearing about in the news all the time? These what looks like really effective weight loss drugs, might they have an impact? So we'll start with the surgery, and there are a number of studies that have shown that weight loss surgery in individuals with severe obesity reduces their subsequent risk of a number of cancers, particularly the obesity-related cancers. So here's one example. This is from Dan Schauer and colleagues. It's from the Kaiser Permanente system, where they set up a sort of a multi-site cohort out of this, and found that about a 30% reduction in all cancers, but particularly about a 40-50% reduction in the risk of developing these obesity-related cancers long after the bariatric surgery and weight loss occurred. So as I said, this is the most consistent story in there. Well, what about diet? Again, here's some evidence, certainly, if you get sufficient weight loss with a diet, lifestyle program. Exercise certainly needs to be in there, and we're going to hear more about that. that you can reprogram some of these metabolic effects and reduce risk. But again, it appears, that particularly from the animal studies, but also most of the human studies, that it needs, you need to move it pretty hard. You have to hit these metabolic pathways sufficiently to reduce that risk. And indeed, we compared various forms of calorie restriction with low-fat diet, with bariatric surgery in our preclinical models, and showed that both are the surgery and the diet weight loss, if sufficient, are effective at reversing the pro-cancer effects of obesity. But interestingly, the calorie restrictions seem to always win. It always seemed to be a little more effective at weight loss, at metabolic alterations, and that seems to be the key, a strong correlation between the weight loss, the number of metabolic markers moved, and the anti-cancer effects. So that's a story that seems to be quite consistent across a number of studies. I'll show you the bariatric versus calorie restriction a little bit in detail. So we took a large cohort of C57 black 6 mice. We kept some on their low-fat controlled diet, so these mice were never obese. We made a large cohort of them obese for 15 weeks on a high-fat diet-induced obese, high-calorie regimen. After that 15-week mark, we either subjected one subset of the mice to a vertical sleeve gastrectomy, that's the most common form of bariatric surgery in the United States, or a sham-operated sort of situation here, where we did the excision, but we didn't remove 60% of the stomach, so they were not sleeve gastrectomized. But they were either continued on their high-fat diet, so that's the continuous obese group, a continuous calorie-restricted diet that they were switched to, so there's the calorie restriction after the obesity. An intermittent calorie restriction, that's a 5-2 regimen, so 5 days of a fairly healthy diet, the control diet really, and 2 days of a very low-calorie, low-carbohydrate regimen. So that's the intermittent. Or the sleeve gastrectomy mice were switched to a low-fat diet as well. And then followed them, we challenged them with an E0771 tumor, mammary tumor, a triple-negative breast cancer model, and then followed their tumor development. So that's the nature of the experiment. What we found was in that 15 weeks, we did get a nice induction of obesity, about 50-gram mice at the end of the diet-induced obesity period. That reversed nicely with really all the interventions, particularly the surgery and the calorie restriction in particular. So the surgery reversed back to the control level, the continuous control. Both regimens of calorie restriction actually overshot below the control, so they lost weight even below where the never obese mice were. And this translated into differences in tumor development shown here. So again, the continuous control here on the left, the continuous obese was the second group. So we saw that, getting close to a doubling of tumor. That's a typical finding in these models. The surgery reversed it back to the control level, so it was effective at reversing the effects of obesity. But again, the calorie restriction, either a chronic continuous, which is really hard to do for people, or an intermittent restriction, which is a little easier for people to follow, were both effective at reversing the tumor growth. And we've seen this in multiple models now of these effects. Now, one thing we picked up, and I mentioned how obesity seems to drive an immunosuppression. And so the question here is, were these weight loss regimens able to reverse that immunosuppression? So we did genomics with gene set enrichment analysis and found that yes, we see obesity really pushing almost every category, every hallmark gene set in the direction of immunosuppression. But each of our interventions was varyingly effective at reversing those immune suppressive effects. And in general, chronic calorie restriction was comparable to the intermittent calorie restriction, a bit better than the sleeve gastrectomy, which was better than the low-fat diet-induced weight loss. And so I do think this immune story is important and a big part of both the pro-cancer effects of obesity and its reversal through whatever diet or exercise or pharmacologic approach we might want to take. Now, where are we with this? So diet and surgery weight loss approaches, they're effective, but there are challenges with them. What about these weight loss drugs is the next question. So this was question 3 of the R35. And just to set this up, that this calorie restriction really does work in animals. Very hard to get people to maintain this kind of chronic, constant, low calorie. The body fights back. All the appetite suppressive sort of effects are reversed, and it's just really challenging. So it's accessible, it's effective, it doesn't cost very much. It's just really hard to do. Bariatric surgery also effective, but highly invasive. There are post-op complications. It's very expensive, and most obese individuals don't qualify for the surgery. So what about these drugs? And so there's particularly these GLP-1 receptor or dual GLP-1 receptor, GIP receptor agonists are really exciting and promising. We've known for a while about semaglutide, which has been FDA approved for both type 2 diabetes and weight loss. It's a single agonist against the GLP-1 receptor. And just recently, actually, I think it was November 21st, the second member here, tirzepatide, a dual GLP-1 GIPR agonist, was approved for weight loss as well. So what is this tirzepatide? And my colleague Randy Seeley will be our next speaker up, who's going to talk more about the mechanisms. But in general, both of these, the GLP-1 receptor and GIP, complement each other really well in terms of their effects. Now, you think about GLP-1, particularly the appetite side of things. Food intake is reduced when that is agonized. There's also effects on the beta cell, so improved insulin secretion and beta cell response. Those are probably the main ones that you think about. Back to this immune question, natural killer cells and CD8 positive T cells overexpress GLP-1 receptor. So we are indeed seeing some effects above and beyond the weight loss of these GLP-1 GIP drugs, directly kind of improving the function and the survivorship of both NK cells and CD8 positive T cells in the tumor microenvironment. So that's a promising direction, I think. When you add the GIP receptor agonism here, you actually get improved beta cell function, so even better insulin secretion, and also some adipocyte biology is affected, I think in really good ways. A browning of adipose tissue seems to be one of the effects that have been recently reported. So Randy's going to tell us more about some of the mechanisms, but what are their effects? Well, this is what caught my eye. A paper now close to 18 months ago, SURMOUNT-1 clinical trial, tirzepatide once weekly for treatment of obesity, and this is sold by Lilly as Mounjaro, and that's the FDA-approved version for type 2 diabetes. Now, for weight loss, it's called Zepbound. So there's Zepbound. It's the same drug, actually the same dosage. The only thing I can tell different, Randy, you may know more about this, is they do include in the package insert advice to drop your caloric intake and increase your physical activity. But it's the same compound, tirzepatide. So for weight loss, it's Zepbound, and that's a new thing as of just 3 weeks ago or so. This drug is really effective at weight loss. So SURMOUNT showed a dose-dependent weight reduction across 5, 10, and 15 milligrams, kind of peaking out really at 10, not much more added at the 15. And so on the order of about 21% weight loss. What else does that? I mean, that's really good. There are some new ones coming, actually, or here that maybe could top it just a little bit. But very effective weight loss in humans in this large SURMOUNT-1 clinical trial. What about mice? Well, we ran through a number of dosing schedules Mice metabolize it much faster, so we don't get away with once-a-week injections. So across a range of once daily or every other day or 3 times a week is kind of what we tested. But you see a very similar kind of curve. They kind of level out here at around 10 nanomoles per kilogram every other day. You get into that 20% range that you see in the humans. And that was really our target. We wanted to aim for a dose and schedule. So our best dose is a dose escalation, starting with really 3, 10, up to 10, and then up to 30. So every 2 weeks escalation. And we found up to about 20 weeks, we're getting consistent, nice, stable weight loss in the 20% range with this regimen. So so it does work in mice. It is kind of like a dose escalation. I think is important to mimic the human. What about mammary cancer? What about its effects as an anti-cancer approach in the setting of obesity? We've got a paper under review at Obesity that says tirzepatide attenuates mammary tumor progression in diet-induced obese mice, and it sure did. It was quite effective. That same regimen, that dose escalation that I just mentioned, we compared tirzepatide versus chronic calorie restriction effects on body weight, that same EO771 triple-negative breast cancer model, and metabolic hormones. And so here you see, looking here at a period when the obese mice were nice and stable obese, and the lean mice were nice and stable lean, we took a group of obese mice and put them on either the tirzepatide or the chronic calorie restriction, and you see the weight loss kind of parallel each other until that 20% mark. In this regimen, and we could do better if we up the dose, but I really want to try to keep the dose in the human range. But a nice 20% consistent weight loss here. This is out through 13 weeks. Again, the calorie restriction did a little better. Continued to lose weight and really kind of changed some of the hormones a little bit better, as you'll see, and was a little stronger in its anti-cancer effect. So as like the surgery, we reversed the pro-cancer effects of obesity. Here's the doubling or so of tumor growth in the obese group that was reversed with the tirzepatide under that regimen. Once again, calorie restriction, a little better, a little stronger at weight loss, a little stronger at metabolic reprogramming and inflammatory changes, and a little stronger at reducing the progression of these tumors. Here's the hormone data. It kind of followed the pattern where obesity made things worse, and tirzepatide and restriction both kind of rescued it back to at least towards the control level. So the hyperglycemia was reversed, hyperinsulinemia reversed, a little better actually by the tirzepatide. That's part of its function with that insulin secretion mechanism. Leptin really changed, a huge bump with the obesity. That was brought back close to the control by both the tirzepatide and the restriction. IGF-1, same picture. Ghrelin, we haven't studied very much yet, but that really follows the pattern where the obesity decreased the ghrelin levels in circulation. Tirzepatide restored it back to the control, and the restriction really bumped it up quite a bit. So that one has caught our eye for some mechanistic work that we're undergoing, in addition to the IGF and leptin in particular. So very effective at reversing some of these pro-cancer effects. So a few key unanswered questions come out of this. Are the mechanisms the same across these different weight loss interventions? Very similar effects to calorie restriction we're seeing. We're seeing some distinction between the sleeve gastrectomy and these others. But I think that's a key one. Can tirzepatide be combined with lifestyle interventions, particularly like the intermittent calorie restriction and or exercise, to really enhance the sensitivity to these drugs or wean them off eventually? Because the problem, and we'll talk more about this at the end, but these are kind of forever drugs right now. As soon as individuals, mice or humans, stop the drug, they regain their weight very quickly. And that's a problem. So can we hand off the tirzepatide, get a nice weight loss, and find the next step in the form of maybe a lifestyle approach that would maintain the weight loss? Is something we're actively studying. Are the effects cancer specific, cancer type specific, and obesity dependent? Our initial data says largely obesity dependent, but again, those immune effects may be independent of the obesity reduction. And so I think there's going to be some interesting work out of that. How does it affect metabolic rate and energy expenditure? What are those effects, particularly in human? We have a metabolic chamber in our shop and are gearing up a chamber study to look at that. Are the prometastatic effects of obesity reversible with tirzepatide? That's a part of question 3, the R35 as well. And then I'll end with this one. Does it work in everyone? And if you hear the SURMOUNT folks, they don't really talk much about heterogeneity, but if you look in the paper closely, there's evidence for pretty large heterogeneity of response. And so we brought that into a diversity outbred mouse study. And what are these? Well, maybe 15, 18 years ago, the mouse genetics community got together and thought of ways to bring the kind of genetics piece into the mouse models. These inbred strains that we typically work with are really not very variable in terms of their the SNPs, the degree of genetic heterogeneity that they have. So the genetics community really worked on this. They developed what's called the collaborative cross, and then out of that, that was 8 strains of mice, including a couple of wild strains in there, to get SNPs in the human range, 45 million or so SNPs expressed in a population of those mice. The diversity outbred are a spin-off of that, where every mouse is a little different genetically. It allows one to do, in a real refined way, a sort of a GWAS study. And so we did that with tirzepatide. And so here's a waterfall plot that shows tremendous heterogeneity. Some mice on this end, here are the super responders. Whoops. You see about a quarter of the mice, were over like 30% body weight loss, some getting into the 50s even. And then there's another quarter that are not responding really at all. Some are gaining weight on the drug or losing just very little bit of weight on the drug. And so I think the human data is backing this up as well, that there's heterogeneity. So I'll close with just some take-home messages. Incretin drugs are really promising. I think these have the potential to be game changers in the weight loss area for sure, and for breaking these obesity cancer links, but they won't work for everyone. These are relatively new drugs, so what are their long-term effects? There's concerns about thyroid cancer. Randy, I'm sure will talk about some of the long-term effects. They're also forever drugs, and so rapid weight gain is a real problem. So we need to find a way to get people off of these at some point in an effective way. And again, I think that combination of weight loss first, maybe with the drug, it's so fast and effective. Get folks to where they feel better and can diet and exercise more effectively, and get that into more of a maintenance mode may be the way to go. So I'll stop here. Here's the group that did the work, and colleagues, and thank you very much for your attention. Thank you. Great. We take questions after.
Wonderful. Thank you so much, Dr. Hursting. So we're going to move on next to Dr. Randy Seeley, who's at the University of Michigan. And as mentioned, he's going to take us on a deeper dive of the mechanisms of the effects of the incretin and dual-incretin to produce substantial weight loss.
Thank you so much. I will start by thanking everybody for being here and for the invitation to come to this meeting. I am a newbie. Please be easy on me. As my wife likes to point out, I am not a real doctor, and so I watch rats eat for a living, and so take it easy. Okay, so first is my disclosure, eventually. You're going to see my disclosures in a minute. My lab works with a lot of different companies that are trying to bring new therapies for obesity and diabetes to patients. In particular, I'm going to talk to you about drugs from both Novo Nordisk and Eli Lilly today, where I've worked as both a paid consultant and they support research in the lab. After you see the disclosure slide, the next slide that you will see is a bathtub, right? And so when we try to talk about body weight regulation, I analogize your adipose tissue to a bathtub, right? That the amount of water that is in that bathtub is a function of how fast the water is coming in and how fast the water is leaving, right? And obviously, if they match, right, the rate of the water coming in and the rate of the water coming out, the level of the water is going to remain the same, right? So, oh, I can? Wow. I can't turn this on. How do I get it up there?
There we go.
Yay! Don't clap yet. You may not like it. So, all right. Disclosures, I've already said. Bathtub. All right? So again, we get into all these issues about exactly how fast things are coming in or out and how they're controlled, right? And again, I think what you have to appreciate, right, is how accurate this system is at being able to maintain the amount of water that's in each of our bathtubs. So if you're an average male like myself, you're going to consume 900,000 calories this year, right? That means that if my body weight is steady, I eat 900,000 calories and I burn 900,000 calories, right? Now again, imagine if you just wanted to gain 1 pound, right? Now again, 1 pound doesn't sound like very much, right? But it's cumulative, right? The pound you gained last year is with you when you gained the pound this year. On average in the US, we're not gaining much more than 1 pound per person per year, right? So again, the point here, right, is that that 1 pound represents 4,000 calories difference between your intake and your expenditure, right? So think of that as an error term, right? How far off are we as a society, right? It's, 0.4%, right, of that 4,000 calories in a pool of 900,000. If you do the math backwards, that is 11 calories a day, right? It's a potato chip, right? The difference between us being an obese society and a lean society really is essentially 1 potato chip per person per day. And I'll tell you that one time I was speaking in front of a group of physicians, and I was doing this right before lunch. Never put the obesity guy on right before lunch. So when I went out and lunch again, they had potato chips, right? And one of the physicians had taken a bag of potato chips and dumped them all over his tray. And I was like, what are you doing? And he said, I'm trying to figure out which one is the extra potato chip. Okay. So he didn't understand the point I was trying to make, right? Which is, again, that we are unbelievably accurate at this, right? And there is no way for us to be that accurate without involving the brain, right? We talk about a lot of different organ systems when we talk about obesity, but the most important in terms of what's going to happen, right, is the brain. And the reason is because the brain is the only organ that's in this position to control both the rate of the water coming in as well as the rate of the water coming out. Now again, in order to be able to maintain that level of water in the bathtub, you don't need to know anything really about actually what's going on in terms of the rate the water's coming in and the rate the water's going out. All you need to know is how much water is in the bathtub, right? And whether it's going up or going down. And we have faithful signals, right, that provide information about how much water is in the bathtub. And one of those signals is leptin, right? Made in adipose tissue is a clear reflection about how much stored calories we have in our adipose tissue, right? And the brain can use that information, right, to, again, change the rate of the water coming in or the rate of the water coming out in order to be able to maintain the levels of water in the bathtub. And again, the system is amazing about how well it does this. Let me show you again, I'm going to use rodent experiments here for you, right? Not because I think they're any different than what happens in human, but we don't have to blame the rodents for what happens, right? And they're compliant with the experiment as it's presented, right? This is a very simple experiment, right? Where these are male rats that are given ad lib access to normal rat chow over the period of 140 days. This is a very long period of the lifetime of a rat. It's a very long period of the lifetime of a graduate student if you're stuck doing this experiment. So over that 140 days, some of these animals are going to be food restricted, right? And again, the animals are compliant with food restriction, as Steve was alluding to. It's very hard to get people to do this, right? And again, it's actually hard to get the rats to do it, Right? If they had any way to get out and change the circumstances they were in, they would do it. And what you can see that is that after 140 days of restriction, when you give the animals back ad lib access to food, they show you where they think they should be, right? They are hungry, they overeat, and they start regaining the weight. And what's important is they don't go back to the weight they were, right? They go back to the weight that they are supposed to be, a weight they had never been. Which the implication is that these animals know, right, that their set point is changing as they age. What the desired weight of the animal, the desired amount of water in their bathtub, is different depending on how old they are. And the animal knows this the whole time, even though it's not experiencing that way. Right? So first thing here, right, is the set point isn't set. Right? What weight we defend can change over different circumstances, in this case, aging. Now, what's important to note, right, is these animals did lose weight, but they weren't very happy about it. Right? And they show you how unhappy they are once you give the food back to them. Well, what if we did this experiment a little differently, right? And looked at what happened on the other side of the energy balance equation, right? What if we induce positive energy balance? And the way you do this, right, is to bypass the normal control of food intake that goes on at the mouth, and put a catheter into the animal's stomach, and we're now just going to infuse food into that catheter. And what you see is that over the course of that 140 days, the animal gains more weight because we're putting in more calories than they're burning, right? The amount of the water in the bathtub is going up. But as soon as you stop that overfeeding regimen, the animal eats very little and loses weight until it gets back to exactly where it should have been. And notice the difference, right? Again, these animals have lost weight but are unhappy about it. These animals are losing weight and they're happy about it. And so the point of everything I'm going to try to tell you from here on in is that successful treatments for obesity don't look like this, right? Where you've induced a weight loss that is engendering a regulatory response for the animal to be more hungry and to try to regain the weight, get back to the set point they were at. Rather, successful treatments are going to look like this, tricking the animal into believing, right, that it is above the line, it is above its set point. In that case, it can lose weight and be less hungry while it's doing it. So let me try to give you some examples for this. Again, let's talk a little bit more about the set points, right? So I just showed you that age can matter to what that set point is. It's not going to surprise you to understand, right, that the food that the animal consumes also changes the set point. So again, this is an experiment where we've given C57 black 6 animals either a standard low-fat diet, right, or a high-fat diet. Now again, our high-fat diet tastes a little like sugar cookie dough. It is yummy enough that you have to keep it away from the graduate students at the end of the month when the pizza money is run out. So, and again, these animals now end up with 2.5 times more body fat than they do when they're on the standard other diet. And again, it's not a mystery about how the animals get here. The animals eat more, right? That's how they gain that weight. And the point is, they are now defending a higher weight because of the circumstance of what the food they were consuming, right? It changes the set point. Now again, so we now know that there's something about the food that the environment the animal lives in, right, that matters to the weight that it will defend. But it turns out the genetics matter too, right? So if you take a different strain of mice, FVBs, and to put them on the same diet, in the same cages, being cared for by the same people, what you see is that they don't gain a whip, right, on it. When you put them on chow, you could not have told the weight of the animals differently, right? But when you can reveal their genetic difference when you put them on a high-fat diet. So the point here, right, is that what the animal weighs is a complex interaction between the environment that we put them in as well as the genetics they bring. So we get into this back and forth about whether weight is regulated by the environment or about genetics, and the answer is both, that the genetic response to the environment we hand them is different, right? And you can see that very plainly here. Again, we all know people who are like this, right? We hate those people, right? That it doesn't matter what they eat, right? In fact, they maintain a relatively healthy weight. So, diet matters, right, to what the set point looks like. There's all sorts of circumstances that matter to what the set point looks like. So just think about this, right? So I don't know how many of you have been in an animal facility, right, to see what it looks like, but the animals are literally sleeping under an infinite supply of food, right? Every time their food runs low, a large bipedal organism comes by and dumps more food in the box for them. How much would you weigh if you slept under your food? I'd weigh more, right? I know that. And it's true for the animals too, right? Because when you give the animals a nest to go to, so they just have someplace else to sleep that is not under the food, they weigh less. They still defend that weight, but they weigh less. Right? So again, the set point isn't set. And I think this is where we get into the problems of the conversation, because when we say set point, what people think of is the thermostat in their house. I set the thermostat for 70 degrees, the house will try to maintain 70 degrees, regardless of what the temperature is outside. But that's not how this works, right? What the temperature is outside matters to whether the house is going to defend 68 degrees, 70 degrees, 75 degrees, right? So again, hopefully that makes things a little simpler as we move forward and try to talk about now about what the therapies look like and what do they do. And again, hopefully you can already anticipate. What I'm going to tell you is that these therapies change the set point, right? They are not obligate anorexic agents, right, with the way we talk about them, right? And in fact, I'll try to show you that here in a minute. So the first thing I'm going to show you, right, is in bariatric surgery, again, using animal models to try to make this case. This is vertical sleeve gastrectomy, where 80% of the stomach is removed along the greater curvature. And the first hypothesis you might have about why it is that vertical sleeve gastrectomy might cause weight loss is because you've made their stomach too small to fit all the food, right? That it's a restrictive procedure, right? You can't fit more calories down your gullet, and so you lose weight. That is a very poor explanation, right, for what actually happens here, and let me try to demonstrate that to you. So this happens to be rat. We do this in mouse too, but what you see in the first two bars, right, are animals that are put on high-fat diet. This is their body fat. And the third bar are animals who are maintained on chow. Now the middle bar animals are going to get vertical sleeve gastrectomy, and we're going to redo this test 34 days later. And what you see is that the animals have lost half of their body weight, half of their body fat, right? They have lost all the body fat that accrued as a function of being on that high-fat diet. They are still on the high-fat diet, right? These animals didn't change their lifestyle, right, in order to be able to achieve this. We do not have a registered rat dietitian telling them what they're supposed to do. This is the biological response to this surgical alteration of what happens in the GI tract. And what I'm going to show you next is how they get there. And the answer is that they reduce their food intake, right? But what's most important about this graph, right, as you can see, is that the animals reduce their food intake for the first couple weeks, and then they go back to eating what they did before. Where's the restriction? Well, I'm going to tell you, right, is that, that we go in and pull the stomachs out on day 20 and compare them to what they look like on day 8. They look exactly the same. This is not because somehow the stomach has dilated to allow the animal to eat more. The animal chooses to go back to eating more. And that's because it's now reached the set point that it now sees as appropriate for the new biology we have given it by changing its GI tract. Now, how do I prove that to you? Well, here's the experiment. We're going to take animals who have either had surgery or a sham procedure, and we're going to, now they've lost the weight that they're supposed to, and they've gone back to eating normally, and now we're going to add on a diet, right? We're going to add on a caloric restriction, right, and force their weight down. If you think of the procedure as being restrictive, it's going to be very hard for the animal to overeat to be able to get back the weight that the animal loses, and we induce that restriction. But that's not what happens, right? So I'm going to change this graph so that everybody starts at 100, so you can get rid of the baseline difference, so you can just see what they're doing, right? And so you can see during the weight loss period, right, everybody's losing weight. We took away their food. When we give them back ad-lib access to food, everybody regains the lost weight, right? That is what body weight defense looks like. And the animals who had vertical sleeve gastrectomy regained that lost weight in a manner that is absolutely identical to the other groups. Where's the restriction? And I can tell you, they do this by overeating, right? So here's one of the control groups, and you can see that after the restriction, they eat more than they were at baseline. Here are two more control groups who do exactly the same thing. The animals, right, who had vertical sleeve gastrectomy overeat in order to get back to where they were before. They are defending a weight. They're defending a lower weight, but they are absolutely defending. And again, the important part, right, is here at baseline, again, after they've lost the weight, right, these animals are eating normally. But remember, they've lost 50% of their body fat. From our outside perspective, there's no water in the bathtub. But the animal doesn't act like there's no water in the bathtub, right? The animal acts like this is absolutely normal. And I can prove to you that this is not just because the stomach is small and I can't fit more calories. It's because when I now food deprive them, the animals will eat more in order to keep up, right? So again, where is the restriction exactly? All right. Is this true for the drugs as well, right? Do we think about this similarly? So this is an experiment using a GLP-1 agonist called liraglutide. This is the once-a-day version that Novo Nordisk had produced. And what you can see here, right, is that, again, just like what you saw with bariatric surgery, there is a temporary reduction in food intake that eventually goes away. You might think that this is tachyphylaxis, right? The drug isn't working anymore, right, because the animals are back to eating. But that's not true, because the animals are maintaining their lower weight. And I can prove to you that this is not tachyphylaxis, because if I take the drug away, what do you think is going to happen? Right? The animals are going to overeat and regain the lost weight. So again, even in this period where the animal is eating the same, the drug is still exerting effect that lowers the set point, but makes the animal totally fine with the idea, right, of matching its intake to expenditure. It does not see a need, right, to overeat in order to be able to regain that lost weight. But as soon as they take the drug away, right, that set point goes back to what it was before. The animal now has to eat in order to be able to get back to that set point. And again, this, I think, relates to a point that Steve made, again, that the use of these drugs, right, is this is a chronic condition that needs to be treated chronically, right? And so we should expect, right, that patients are going to be on these drugs for some long period of time. Now, let me try to convince you, right, that again, this is all happening in the brain, right? So the experiments I'm going to show you involved us using a variety of genetic tricks in order to be able to knock out GLP-1 receptors either in peripheral nerves or in just the brain, okay? And I'm going to ask about what the effectiveness of the drugs are in that context. So this is normal versions, right? Again, animals getting liraglutide, right? They reduce their food intake. This is a very reliable effect. In fact, this is the way we test graduate students. If you can't see this effect, you need to find another laboratory. If we get rid of GLP-1 receptors in the peripheral nerves, doesn't matter. If we get rid of GLP-1 receptors in the brain, however, again, almost all of that effect on food intake goes away. If you look at body weight, this is true as well, right? So again, these are animals getting vehicle. These are animals getting liraglutide, either, again, control animals or animals that, again, we've knocked out GLP-1 receptors in the peripheral nerves, doesn't matter. But the animals who don't have any GLP-1 receptors in their central nervous system, entirely resistant to the effects of the drug. What's happening here, right, is that these drugs are acting in the central nervous system in order to produce these effects. And let me just point something out here, right? This is all pharmacology, right? This is not reflective of what the GLP-1 system actually does in normal physiology. It is an analog of a gut hormone, but that gut hormone rarely gets into the brain. What we see in these drugs, right, is you are giving folks 5 times what you would see in terms of the GLP-1 levels that you would get after Thanksgiving dinner, right? So this is pharmacology, right, that happens to be very effective as a therapy. Now I have to point something out. So the major side effect of these drugs is nausea, right? And it is limiting, right, for many patients in terms of whether they can tolerate the nausea. And again, good use of these drugs, they titrate in, right, slowly increasing the dose in order to be able to limit these effects. But the question is, where are these effects happening, right? Are these effects happening in the brain as well? So you have to figure out, how do you ask a rat or a mouse whether it's sick or not? They don't vomit, right? So how do you do this? Well, I'm going to tell you the trick that we use is one that almost everybody in this room has had an occasion to experience, and it's called a conditioned taste aversion. I can tell you that mine happened with tequila. So the first time I had tequila, it was an unusual flavor. It was followed several hours later by nausea and vomiting. We do not have to talk about what happened in the intervening period, nor should we talk about dose, okay? But the point is, I can't touch tequila now, right? There's a Margaritaville over there, and just the idea of going near it actually kind of skizzes me out, right? It makes you nauseous to actually see or smell the stimulus, right, that you've been associated with, right? Again, I know cognitively, right, that if I didn't drink as much as I did that night, I'd be fine. I still can't touch it. Right? And we can do this in an animal, right? So we give the animal a saccharin solution, then we pair it with something that makes the animal sick, like lithium chloride, or our drug of choice, right, a GLP-1 agonist. And then we come back several days later and say, do you want to have that flavor again? And the animals show you very clearly, right, that they don't want to have anything to do with it. So you can see here, right, that lithium chloride reduces their preference for saccharin. In this case, that's the state stimulus. And so does liraglutide, right? These are very potent at producing conditioned taste aversion. But interestingly enough, right, if you knock GLP-1 receptors out of the peripheral nerves, it doesn't matter. But if you knock GLP-1 receptors out of the brain, it absolutely matters. So despite the fact that people experience those symptoms as something that's happening in their GI tract, it's not. It is something that's happening directly as actions of these drugs in the central nervous system. Okay, so again, the brain, right? So my first set of conclusions, right? Body weight and body fat is regulated and subject to a set point. The key signals to the CNS reflect whether the individual is at their set point, right? Leptin being one of those signals. The set point isn't set. Genetic and environmental factors affect the set point. And finally, effective therapies for obesity target the brain and alters this set point. We cannot be effective in helping people lose weight over the long run without having some ability to change that set point. Now let me try to dig a little deeper here right into these mechanisms and help you try to understand, again, a little bit more about how it is that they work. And so we continue to use these genetic tricks, right, to ask which populations of neurons are actually important for these effects. So again, everybody here knows, right, that your brain is divided into two kinds of neurons. Neurons that are inhibitory and neurons that are excitatory. And we can knock them out we can knock GLP-1 receptors out of each of those independently using a variety of crees that, again, I won't bore you with the details, but allows you, again, to now just take down GLP-1 receptors in either the excitatory neurons or in the inhibitory neurons. And what you see here, right, is weight in animals that had either gotten vehicle along the top. Again, on the bottom are the animals that have got liraglutide administered either to normal controls or the animals who had knockdowns in the GABAergic, the inhibitory neurons. And you see it's absolutely normal. But what you see in green here, right, are the animals who had GLP-1 receptors knocked down in the glutamatergic, the excitatory neurons. And you can see very clearly, right, that effect is almost entirely gone, right? This is true, again, when we go back to the conditioned taste aversion, right? Is it these neurons that are also the important ones for that? And the answer is absolutely, right? So you see here, again, the effects of both lithium chloride and liraglutide in normal animals, right, to cause a conditioned taste aversion, in the inhibitory neuron knockdown, and almost entirely absent for liraglutide in the excitatory. Again, notice it doesn't matter for the lithium chloride, right? Again, this other stimulus, these neurons are not important for. GLP-1 signaling is not important. It's not an endogenous signal, right? This is about the pharmacology, what happens when we give these doses of a GLP-1 analog. Again, it's the brain. Right? So now let's add on something here, right? So Steve already alluded to the idea, right, that what is now coming, right, is polypharmacy delivered in a single entity, right? So this is, again, the sequence of peptides, right, that are involved for GLP-1. And this is the sequence used for one of the GLP-1 drugs called exenatide. And you see, it is altered to make this longer lasting, right? So GLP-1 has a very short half-life in the plasma. These drugs can have very long half-lives. GIP, and the second gut hormone, right, has a different sequence than GLP-1, and you can combine those sequences in very clever ways, as they have done in tirzepatide, to make it an agonist for both the GLP-1 receptor and the GIP receptor in a single molecule. One of the things that's important, these are not just things stuck together, right? This is a single peptide sequence, right, that actually is capable of turning on both sets of receptors. And this is data that Steve already showed you, right, that, again, these coagonists are more effective, at least of the ones that we have, than what we've been able to do with a single agonist. Great, right? Here's the problem. I can tell you that as these drugs are being developed, there was a great deal of controversy about whether we should be trying to turn on GIP receptors or should we be trying to turn them off. Because the genetics says you should turn them off. So this is a whole body GIP receptor knockout put on a high-fat diet, and you can see those animals, right, that lack GIP signaling, right, are skinny. That would seem like maybe we should supposed to be turning this off. Again, lots of companies worked on the idea of turning them off. So this is actually a molecule from Amgen in which they built an antibody that is a GIP receptor antagonist, and onto the antibody they hooked on GLP-1 agonists. And what's interesting, right, is that both parts of that molecule are important, and you can see very potent reductions in weight. So this is the GIP antagonist alone, has no effect on its own. Here is the GLP-1 agonist by itself, and when you combine the two, right, you get a much bigger effect. And again, in the early clinical trials, they are seeing excellent weight loss in patients as well. I hope you're all shaking your head saying that this makes no sense, because it makes no sense, right? The idea that we can end up at the same place by turning on the GIP receptor or turning it off, right? It's crazy, right? So how do we square this circle? So let me give you just a few minutes of work that we're trying to do. So again, we're going to use the same kinds of strategy that I showed you before. We are going to work to knock down the GIP receptors either in the excitatory neurons or in the inhibitory neurons and ask whether that changes the effect of a coagonist to be able to matter. All right? Same thing that I showed you before. This is the global knockout. This is a split violin plot, right? And where you can see that the knockouts weigh less in terms of body fat, or body weight and body fat. If you knock GIP receptors out of the excitatory neurons, nothing happens. Right? These are not important. But when you knock them out of the inhibitory neurons, it absolutely is important, and you can completely recapitulate what you see with the global knockout. Here's what's interesting, right? So now what we did was we took these animals and we give them a GLP-1 agonist or, again, tirzepatide, right, the coagonist. And what you see is that, in fact, that for both semaglutide and tirzepatide, the drugs are more effective in a model where we lack GIP signaling. Again, I hope that makes no sense to any of you. Right? I've just told you that adding on a GIP agonist onto a GLP-1 agonist makes it better. And now I'm showing you that that drug is even better when I get rid of the GIP signals that it's supposed to be driving. Again, how does that make sense? This is now, again, we can do the same experiment in the GABAergic knockout and get exactly the same response, right? So this is not just about GIP receptors in random places. It is GIP receptors in the brain, and again, they are on GABAergic neurons. All right, here's the critical experiment, right? So what we did was to take animals that, again, are either GIP receptor knockouts, right? Again, GABAergic knockouts, and now we're gonna add on a GIP onto the semaglutide and onto the tirzepatide. So the real answer to this, right, question for why it is that this works is because the tirzepatide is actually not a very good GIP agonist in a mouse, right? So again, we're going to make it more like tirzepatide by adding on GIP to it, right? So we're going to co-infuse the two. All right. So here's the effect of tirzepatide, right, in the wild-type animals and in the knockout animals. Again, lacking GIP signaling makes the tirzepatide more effective in terms of weight loss. Now we give the animals tirzepatide plus a GIP receptor agonist, right? So we're going to turn it and make it more like the human tirzepatide. And you can see we get way more weight loss than with tirzepatide by itself. Again, adding GIP matters. But what you'll notice, right, is that when we do it in the knockouts, that effect entirely goes away. And you get exactly the effect that you'd expect for tirzepatide alone, right? In response to without any GIP agonist on, right? So again, it makes sense, right? These neurons and GIP receptor signaling matters, right, in terms of being able to reduce GIP signaling, can actually make them more effective, but it's also part of how the coagonist works, right, is to activate those neurons, activate signaling through those neurons. And again, this turns out to be true for the taste aversions as well. Again, that in the knockouts, they are more effective to produce a taste aversion. I've been terrible to you, right? Again, it's clear that the GLP-1 receptors are in excitatory neurons, Again, I won't worry with the details here about they're likely in an area of the brain called the area postrema. Both GIP receptor agonism and antagonism can improve efficacy of GLP-1 receptor agonists. And key GIP receptors are also in the brain, but are an inhibitory neuron. So here's the really important point. On the beta cell, GLP-1 and GIP, right, to act to help increase insulin secretion by acting on the same cell. That is not what's happening in the brain. They're acting on different sites in the brain, different sets of cells, in order to change that circuit to more potently change what happens in terms of what the set point that is defended. It's the brain, it's the brain, it's the brain. I will stop there, point out that I didn't do any of the work you just saw, right? It's a group of this talented folks at the University of Michigan. So thank you very much for the leniency, right, to have me here and talk to you today. Thank you.
Thank you so much, Dr. Seeley. And so next we're going to hear from Dr. Kerry Courneya, who's going to be giving us another really important piece of that puzzle of obesity-associated breast cancer risk, which is the impact on breast cancer, the impact of exercise on breast cancer outcomes. And please stick around after the presentation, because we'll have an opportunity to ask questions and have an interactive session. Thank you.
Thank you. Good afternoon, everyone. Pleasure to be here and share with you some of the latest research on exercise and breast cancer outcomes. Thank you. I have no disclosures to report. In terms of overviewing this presentation, I'm going to take a different approach about the role of exercise compared to what's been done typically. I'm going to focus on exercise as an actual breast cancer treatment, so coming at it from a clinical oncology perspective, where most of this research has really approached exercise from a public health or cancer survivorship perspective, looking at kind of a single exercise prescription for all breast cancer survivors. So this will be a different way of looking at exercise and improving breast cancer outcomes. So I'll start by summarizing the current animal and human studies on exercise and breast cancer outcomes after I present initially a framework about how we can think about exercise as a cancer treatment. And then I'll critique existing studies kind of from this treatment perspective or this clinical oncology perspective and how we might be able to improve future research to make it more relevant for clinical oncology practice. So when you start talking about exercise as a cancer treatment, it's widely accepted in the oncology field that the research study should reflect clinical practice. We should try and recapitulate the clinical environment as best we can. You'll see this in some of the preclinical exercise oncology research. They're aware of this issue, they attempt to replicate the clinical environment, but it can be very difficult. And that's because the breast cancer treatment landscape is very complex now and expanding rapidly with new treatment options. So we do these very simple preclinical animal models that don't really replicate this very complex treatment landscape. But those preclinical researchers are aware of this issue. When I read the epidemiology literature, I get a sense that they don't follow this principle. They're not concerned about sort of does this research replicate a clinical oncology environment where we can give a specific prescription at a specific time point. And this is where I would say it's more of a public health perspective, more of a cancer survivorship perspective, where we wait until all the treatments are done and then maybe give some sort of general recommendation to exercise after that. And because of this, I think current exercise oncology research has limited clinical utility, at least for the oncologists. So we've proposed a conceptual framework to try and facilitate a more systematic and clinically relevant approach to the study of exercise as a cancer treatment. And we proposed this framework a year or two ago. And again, it's just this idea of trying to apply a clinical oncology framework for exercise oncology researchers to follow. And I did this framework in conjunction with Chris Booth, who's a medical oncologist at Queen's University. We call this the Exercise as Cancer Treatment Framework, or the EXACT framework, and it really proposes two key clinical oncology variables: the tumor disease status and the treatment status. And we look at these from the perspective of an exercise intervention. So what's the tumor disease status of the patient at the time of the exercise intervention? And what's the treatment status of the patient at the time of the exercise intervention? So when we're doing exercise interventions in the breast cancer setting or other solid tumors, there's three basic scenarios that we're going to be tapping into. The first one is where the primary tumor is removed. So in the case where the primary tumor is removed, which is sort of your stage 1, stage 2 disease, we call the adjuvant setting, the goal of exercise there is to treat any micrometastases that have been shed from the primary tumor before the surgery occurred. The second setting is where the primary tumor is present. So this is typically your stage 3 neoadjuvant setting. So now we're able to do exercise where the primary tumor is present. So the clinical issue there is what's the effects of exercise on the primary tumor itself? Can it treat the primary tumor? And the last setting is where the patient presents with metastatic disease, which is your stage 4 breast cancer. And there we're looking at the role of exercise in treating metastatic disease. And these three scenarios represent very different steps in the metastatic cascade, from the growth and spread of a primary tumor to circulation of the tumor and dissemination of cells, formation of micrometastases, and then ultimately macroscopic disease. And those different steps in the metastatic cascade require different interventions, but they also represent typically different genetic disease. The metastatic tumors are genetically different from the primary tumors, and sometimes even the different location of these metastatic disease sites have different genetic mutations. So the role of exercise in those scenarios may be very different. Just because it treats breast cancer in the primary tumor setting, it may not treat micrometastases or metastatic disease. The other key variable is treatment status. So what is the treatment status of the patient at the time of the exercise intervention? We can intervene when the patient is treatment naive, meaning the disease has not been given any other cancer treatments yet. We can intervene while the disease is being actively treated. This could be first-line therapy, this could be later-line therapies as well. Or we can intervene after patients have been treated for their cancer, and in some cases, heavily pretreated for the disease. This is absolutely critical. All these treatments may alter the genetics, the biology, and the newly acquired mutations of those cancer cells, and also the location of any remaining cancer cell. And because of that, these treatments may alter the subsequent effects of exercise. Based on any additional mutations that they've gone under, exercise might be more or less effective. And the reverse is true. Exercise has biological effects on tumors as well. So it's possible that exercise might alter the efficacy of subsequent cancer treatments. So in clinical oncology, you guys are very aware of this issue. As the treatment landscape becomes busier, this idea of how you sequence treatments, how you combine treatments becomes critically important. In the exercise science field, we've largely ignored this issue. This idea of how do we sequence exercise in a very busy treatment landscape. We've sort of taken the general assumption that the effect should be the same no matter what, whether we're treating naive disease, whether it's actively treated, whether it's being treated with chemo or immunotherapy, whether it's been previously treated. We just figure the biological effects should all be the same. And that, of course, is a faulty assumption that doesn't really pass the test of biological plausibility. So if we think of this overall as a very simple framework that gives a high-level overview, you can see there's kind of 9 generic clinical oncology scenarios in which we could test exercise as a cancer treatment. And just to sort of give you the big picture of where we're at in terms of the research, if you look at all the preclinical studies, they are largely in the treatment-naive setting. So the animals get no other treatments, and we look at the effects of exercise on treatment-naive primary tumor, which then typically metastasizes, so we're looking at treatment-naive micrometastasis, and ultimately there's a number of metastatic lesions, so we're looking at treatment metastatic lesions. So these preclinical models look at exercise across the entire metastatic cascade and treatment-naive disease. When you look at the epidemiology studies that I'll share with you, all of them fall into this category here, almost all of them. They're looking at primary tumors that have been removed, the early stage setting, and they're looking at physical activity measures that are well past treatment. So they're asking the question, does exercise improve survival with previously heavily treated micrometastatic disease? Very different than the questions being asked or addressed in these preclinical models. So with that as a backdrop, let's move into what we have in terms of research. Now, there's no adequately powered randomized control trials of exercise with a breast cancer outcome as the primary endpoint. We do have a couple trials that have reported secondary analysis. They tend to have a small number of patients, and again, recurrence and survival were not the primary endpoints in that study. So we don't have a lot of randomized control trial data, and I'm coming around to the reality that we're probably not going to have a lot of large-scale phase 3 randomized controlled trials of exercise and breast cancer outcomes. And this is why the epidemiological evidence is going to be so important, but I think we can improve it substantially. So most of the studies, most of what we know about exercise and breast cancer outcomes are based on these observational cohorts. But even there, few of these studies have been designed to examine exercise and breast cancer outcomes. Oftentimes, they're healthy cohort studies that are parlayed into a breast cancer survivorship cohort after healthy people get diagnosed with breast cancer. But even the ones that are breast cancer survivor cohorts, very few, if any of them, have exercise as the primary focus. It's very much a secondary focus where they might have a self-report measure of exercise. Interestingly, there's growing preclinical research, which does come at exercise a bit more from a treatment perspective that I'll talk about. So that's a growing area of research in the exercise oncology field. And then we do have some clinical studies with mechanistic or biomarker outcomes, which can be very helpful in this field. So let's start with the preclinical models. These are typically rodent models looking at the effects of exercise and tumor growth and spread. And we've just followed the same design as the drug trials or even the nutrition trials as well, where we can implant these either primary tumors, small number of cancer cells, and randomize these mice or rats to an exercise arm or no exercise arm, and then track the growth and spread of the tumor. So we can test exercise the same way that it's tested in these drug trials. Right now, there's about 50 studies that have looked at exercise in these preclinical animal models. And this is the general finding across all of these studies. Here's what we typically report. And what you can see here is that exercise generally will slow the growth and spread of these tumors and disease over the course of time. So it looks like there's some anti-cancer effects of exercise across these tumor models, including some breast cancer models. But what you can also see by looking at this figure is in none of these studies do we have a complete response to exercise. None of these studies eliminate the tumors. In fact, none of them even reverse the tumors or shrink the tumors. And I haven't even seen any that result in stable disease. So the best case scenario is we're slowing the progression of this, of these cancers. So it's clear that exercise as a single agent or monotherapy treatment is not going to cure any type of cancer. In fact, about a quarter of the studies show no effects at all. Those lines are right on top of each other. And unfortunately, in about 10% of these studies, we show the exercise animals, the tumors grow more quickly. So this is not a home run by any stretch of the imagination. And so we do have to be careful about, hey, exercise is good for every tumor type in every breast cancer situation. But generally speaking, it looks like exercise has some anti-cancer effects. The mechanisms are a lot of the ones that Steve talked about in his talk, very similar to the obesity mechanisms. Improvements in insulin, IGF, a lot of improvements in anti-inflammatory markers, effects on the immune system, sex hormones, and other apoptotic pathways. So we have good biological plausibility for how exercise might be able to address these breast cancers. But again, it's all in these treatment-naive models where there's no other treatments being given. And except for maybe active surveillance in prostate cancer, we don't have a lot of scenarios where a primary tumor is left intact and is untreated. Certainly in the breast cancer setting, I'm not aware of how exercise researchers could be addressing a treatment-naive primary tumor or even micrometastatic disease. So we have bumped up our game a little bit with slightly more clinically relevant design studies, and we're able to combine exercise with an accepted cancer treatment. Oftentimes a chemotherapy drug, but more recently immunotherapy and even radiation therapy. And now this is a pancreatic tumor line, but there's a couple studies in breast cancer line. Overall, there's about 15 of these preclinical studies where we're able to randomize the animals to exercise plus drug or the combination. And here you can see an example with gemcitabine. And what you can see here, this is one of the cases where exercise itself has no effects on tumor growth and spread. The drug works as expected, but exercise improves the drug. And again, this is a fairly consistent finding in these preclinical models, that when you combine exercise with drug, you get a better response than the drug alone, even in scenarios where exercise makes the tumor grow more quickly. So this is not an additive effect of two things both helping a little bit. It's clearly exercise is somehow helping these drugs perform better. We have a pretty good idea of what those mechanisms are. And we think it's related to improved angiogenesis and intratumoral vascularization. So exercise, these tumors, the blood vessels in these tumors do not constrict during exercise. So they get a significant increase in blood flow. And this improves the angiogenesis, the quality of the vasculature, and how well the blood is perfused into the tumors. And of course, increase blood perfusion into the tumor is going to be better drug delivery or more drug delivery. So we think that's the mechanism for these trials showing better immunotherapy response, better chemotherapy response, or these preclinical studies, I should say. It of course, also decreases intratumoral hypoxia. And this becomes the mechanism for a better response to radiation treatments because these are better oxygenated tumors, and there's been some research on that end of things. And it does increase intratumoral immune cell infiltration as well. So all sorts of biological factors are being delivered to the tumor much better in mice that exercise than those who don't exercise. So that's kind of the preclinical data that we have, and that's about as sophisticated as we get in terms of the preclinical data. Moving on to the human data, which is almost all exclusively observational studies, at least linking it to the breast cancer outcomes themselves, recurrence, death from breast cancer, and death overall. We have a lot of these studies. Probably about 40 or 50 of these observational studies have been looked at. And these studies all do typically a single measure of pre-diagnosis physical activity or a single measure of post-diagnosis physical activity, and then link it to one of these clinical outcomes. And the research shows, there's lots of these systematic reviews, show the same sort of thing. Pre-diagnosis physical activity is associated with a lower risk of death from breast cancer. Post-diagnosis physical activity is associated with a lower risk from breast cancer as well, all based on these self-report measures, typically taken at one time point. So for those of you who follow this field kind of tangentially, this is the conclusion that you'll be most familiar with. This is what's concluded after every single systematic review. Higher pre-diagnosis and or post-diagnosis physical activity is associated with improved breast cancer outcomes. So there seems to be some link there, but as you can see from this conclusion, it's not a very precise conclusion or very helpful for clinicians to say that we should be recommending post-diagnosis physical activity when you have a very busy, complicated breast cancer treatment landscape. The reason this is the case is this is the design, as I mentioned, that these studies follow in terms of assessing physical activity. If you're doing kind of a healthy cohort, you've got some sort of random pre-diagnosis measure that's oftentimes 2 to 5 years before the patients go on to get diagnosed. And then typically the next measure after that, which is several years apart, is 2 to 5 years post-diagnosis. So what you can see in these study designs is we skip over what I think is the most interesting part of the breast cancer trajectory, which is the whole treatment landscape. And I'm just showing a very simple one here. From diagnosis, there's some pre-treatment time point before the first treatment is initiated. You typically have 6 to 12 months of a first-line treatment that may include chemotherapy, radiation therapy, biologic therapy, endocrine therapy could be started then as well. So this is the clinically interesting and relevant time point, but the measures skip over that. And oftentimes, the authors of these studies actually promote this as a good thing. You say, we skipped over the treatment time period because exercise is not stable when you're on chemotherapy or you're on radiation therapy. So maybe we want to leave that time point alone and get to the survivorship phase when self-reports of exercise will be more stable. As I mentioned, though, this may be the most clinically relevant time period for exercise because exercise alone is not going to treat breast cancer. It's going to be some sort of combination of exercise with many of these other treatments. So these clinically relevant time points are avoided, and sometimes they're even mixed, which means you get a 2-year post-diagnosis measure, and patients are asked to recall the 2 years since diagnosis. So this cuts across chemotherapy and radiation therapy and endocrine therapy and so on. So now you don't know what you've got in that measure. And so what you can see from these study designs is treatment combination and sequencing, which we know is critical in the clinical oncology field, is virtually ignored in the exercise oncology field. So we're treating exercise just as a public health or general cancer survivorship behavior. And of course, you miss all the early events and treatment responses. So some limitations of current research. There is a disconnect between the clinical scenarios addressed by animal and human studies. Most animal studies address treatment-naive tumors or disease. More recently, we're doing some of these combined treatments. So really, in these preclinical models, we're testing exercise as a first-line monotherapy to treat the entire metastatic cascade. That, of course, doesn't exist in the clinical world, but there's still some scientific and biological evidence that's gained from that. But it's not clinically relevant, I would argue. Most human studies address previously treated micrometastases and sometimes heavily pretreated micrometastases. So here, we're studying exercise as a maintenance therapy for the later steps of the metastatic cascade. And most studies, as I mentioned, do not address treatment sequencing. The animal studies do not address exercise before or after standard treatment. So we don't know, should exercise come first before treatment? Should it come immediately after? We're starting to get some evidence about during some of these treatments. Most human studies ignore when exercise is performed in relation to treatments. So we don't collect data before, during, between multimodal treatments, or immediately after. And most human studies ignore all these treatments, the type, the modality of a treatment, the number of treatments, or the sequencing of either subsequent treatments after exercise or previous treatments before exercise. So we largely ignore the treatment sequencing issue. So to address this issue, a colleague of mine, Christine Friedenreich, and I put together a paper to try and articulate how we could design, analyze, and interpret these observational studies from a clinical oncology perspective or a cancer treatment perspective, acknowledging that large-scale phase 3 trials are unlikely in many of these clinical scenarios. These observational studies might be the best we get, but they've not been designed from this perspective. So our recommendations: recruit clinically homogeneous samples, both in terms of disease and the treatment scenarios. or analyze these clinically homogeneous subsets of patients. Collect detailed cancer treatment data. Almost all these observational studies either have no treatment data or they simply have yes-no for the major modalities, chemo, yes-no, radiation, yes-no, and so on. Probably the most important recommendation, though, is to assess exercise in relation to cancer treatments, rather than arbitrary time points, pre-diagnosis and post-diagnosis. So assess exercise before, during, between, and after treatments. Ask questions about, did you exercise during chemotherapy? What was your exercise during radiation therapy, or when you were on a biologic therapy? And include, of course, when you do that, you'll be able to look at these early cancer-specific outcomes. And the last recommendation is to analyze subgroups of these patients based on cancer treatments. We do subgroup analysis in these EPI studies based on age, menopausal status, BMI, sometimes some disease characteristics like ER positive, ER negative, but we ignore treatments as if to say previous treatments and previous combinations of treatments don't matter. They don't influence any sort of benefit from exercise in terms of cancer outcomes. But we should be analyzing these data based on these individual treatments, based on the combinations of treatments patients have received, and sequences to find out, is exercise more effective depending on which treatments and what combinations of treatments you've received, and also what's the sequencing of exercise that's optimal from those treatment perspectives. So here's a simple example of one study that's kind of done this. You can see here by the title, they talk about physical activity before, during, and after chemotherapy. And they did a pretty good job of measuring those separate times, the before, during, and after. And they were able to do this. This was a phase 3 drug trial where they piggybacked some measures on top of a trial that was comparing different chemotherapy regimens. And I'll talk more about that in a moment. But they're able to show some interesting findings about how the timing of exercise in relation to chemotherapy might be more or less effective. And that, to me, is more clinically relevant information. So future research directions. I think analyze existing observational studies to better emulate clinical oncology scenarios. Sometimes we use the term target trial emulation, where we're trying to design these studies to really look at these clinical scenarios from a clinical trial perspective. The problem with the exercise field is the data don't exist. So we don't have the exercise data where we can apply target trial emulation. We need to design these studies so we can, in fact, apply target trial emulation by collecting measures of exercise before, during, between, and after all these different treatments. I think piggybacking exercise on phase 3 clinical trials is a promising approach. You get a clinically homogeneous sample, you've got clear treatments. It still has to be done properly in terms of the exercise measures, but I think that's a promising approach. Prospectively design new observational studies to better emulate clinical oncology scenarios rather than public health or cancer survivorship scenarios. And then conduct some targeted RCTs. So just to give you an example of a couple ongoing studies, this is a cohort study we started back in 2012 called the AMBER cohort study, the Alberta Moving Beyond Breast Cancer. And it's a prospective study, and it's designed from the perspective of physical activity and health-related fitness. So we have not just self-report measures, we've got objective accelerometry measures as well, and then all of the gold standard fitness measures. And we've recruited over 1,500 newly diagnosed breast cancer patients. We assessed them before treatment, right after diagnosis, at 1 year, 3 year, and 5 years. So we've got multiple follow-up on these patients. We didn't tie the measures to treatments, so this is not a perfect cohort. We conceived this back in 2010 before I started thinking about this idea of exercise as a cancer treatment. So our measures don't line up perfectly with treatments, but I think it's an improvement over current observational studies. And there is one large-scale randomized trial going on that's been initiated, looking at the role of exercise during neoadjuvant chemotherapy for breast cancer as a mean to increase pathological complete response rates. So kind of that idea that exercise might improve delivery of chemotherapy to these tumors and increase the rate of pathological complete response. And they're going to randomize about 780 patients in this study. So it's a large-scale, definitive phase 3 trial in a fairly narrow clinical scenario. But I think this will be a fantastic study if they're able to complete it successfully. So in conclusion, exercise slows breast tumor growth and spread in rodent models. That's the general finding, but it's unclear which steps of the metastatic cascade are affected by exercise. And it's unclear when exercise is effective in combination with standard treatments, before, during, or after, especially when you get into multimodal combination treatments. From the observational studies, we see that exercise is associated with improved breast cancer outcomes, but it's unclear if exercise is effective before, during, or between the standard treatments that breast cancer patients receive. And it's unclear if exercise is effective after all treatment combinations and sequencing. Or are there particular combinations and sequencing where exercise might be most helpful in terms of improving breast cancer outcomes? Ideally, we have some translational studies, animal and human studies, that kind of replicate the same clinical oncology scenario and are able to address a specific scenario where we might make a more specific exercise recommendation. So the goal of this is precision exercise oncology. We want the right exercise prescription for the right breast cancer patient at the right time. These observational studies have helped us with the right exercise prescription and the right breast cancer patient, but they've not addressed this issue of the right time. That is, the role of exercise within the combination and sequencing of existing cancer treatments. Thank you very much for your time.
Wonderful. Thank you, Dr. Courneya. So we will open it up to questions, and if you can, please introduce yourself when you come to the mic. I see we have one question in the middle aisle.
Rick Blecher, Fox Chase Cancer Center in Philly. Great talks. So obviously we want to set patients up for success long-term, not just short-term. And we also know in certain cases of some hormones that we give patients, we can permanently suppress their axis of whatever hormone that is. So you give somebody something, it suppresses what they make endogenously. Long-term, some cases for certain things we give patients, we permanently suppress it. So in cases where we're giving patients these exogenous GLP-1, GIP, what is the data regarding what we're doing to them long-term? Are we conceivably setting them up for higher risk of obesity long-term and therefore higher cancer risk? And then with the other interventions, what do those do to these hormones specifically?
Can you hear me? Is it on? Yeah. Okay, good. So this is an excellent question. I think what's for the GLP-1 agonists, we have much longer term data, at least in type 2 individuals with type 2 diabetes. Right, so this class of drugs has been around for 17 years. So while we talk about it as very new, right, for the treatment for obesity, but it isn't new, right, in the use of these drugs, right? And you do not see the version that you just said in terms of the rebound. And part of the issue here, right, is that the GLP-1 system is not essential for normal body weight regulation. So when you knock out GLP-1 or GLP-1 receptors, you actually get an animal that tends to be leaner. So what we're doing to the system, again, has little to do with that normal physiology, and that normal physiology of that GLP-1 system is not, again, in terms of the peripheral levels, is not really related to body weight regulation in an essential way, the way leptin is, right, as an example. So, again, I don't know of any data that would say that we're actually increasing risk for obesity over the long run by treating it in the short run.
Just to add to that, I will say that I think in practice, the issue, people are on these drugs for a short period, lose weight, and then they have to come off because insurance stops or their other symptoms, are worse. And I think the evidence is pretty clear. At least with tirzepatide, I'm most familiar with, they gain weight pretty rapidly and actually can overshoot often. Certainly that's true of the mice. As soon as we stop the drug, my goodness, they gain weight quickly, and it's all adipose tissue, and they're metabolically worse. So that is a concern, I think, maybe at least with some of these drugs, and probably the way we dose them, too.
Well, again, I think what's been true, right, is I think a lot of people believe that when we move from once a day to once a week versions of these drugs, that the compliance rates would and the long-term use would go up. That hasn't really been the case, right? There's still lots of patients who are discontinuing, not just for financial issues, right? That absolutely happens as well, but for reasons that are unclear. One version is that some patients believe, I'm not losing any more weight. I know how to do this now. I don't need this drug in order to be able to do that, right? And again, I think they talk themselves into the fact that that coming off the drug, right, is actually the right thing to do. Again, I just think that the right analogy here is hypertension. Nobody thinks that their blood pressure is going to stay down when they stop taking their hypertensive drugs.
Yeah, that's a good call. What do you think are the strategies to maintain once the weight is lost and once the metabolic health is restored?
In terms of post-drug?
Post-drug. Because if you know, we get 300 million people on these things, not everybody's going to be able to stay on them, I don't think. And so we need a solution, don't you think, of getting, I mean, is lifestyle going to be enough to maintain, you think?
Again, post the drug, the lifestyle intervention that you imagine will be just as effective as it was pre-drug, right? I don't think there's any reason to expect
So it's off, on.
Yeah, so there might be the idea that there might be drug holidays, right, that people take, right, is a possibility. Or again, as we get more tools, that they transition to other therapeutic strategies. But again, we don't expect people with diabetes, right, to be able to keep their blood sugar low without their insulin. We don't expect the people with hypertension, right, to be able to keep their up without, and I think this is exactly, it's the same biology, right? Once you admit that it's a regulated parameter, right, even though it involves a behavior as well, right, then it becomes easier to think about what is going to happen when we do it.
Let's get another question on the aisle to my right.
Hi, Susan Tannenbaum, University of Connecticut. I appreciate the discussion today very much, but I think we're sort of missing the mark a bit, and I think you just talked about it right now, which is lifestyle is what really matters. And if we're going to say people aren't going to change their lifestyle, then we're sort of throwing up our hands and putting it within the hands of pharmaceutical companies and our food industry. You know, it's the same thing with tobacco. In the olden days, we said, oh, people are just going to smoke, but we put things into place where they stopped. And I think whole food, plant-based diets, exercise, things that we can do. People want to make these changes, and I think that's the only thing that we have in our power. And social determinants of health very much have to do with this as well.
Yeah. That's a great comment. I will say there's a recent SURMOUNT-3 study that did, to me they did it backwards. They did the intensive lifestyle first, and then they picked the ones that were responsive on the intensive lifestyle, and then put them on tirzepatide. And they did better. I mean, they were like 28% weight loss. To me, the question is, what if you got, maybe the drug is going to be important for getting at least some people who can't do it by diet and exercise to get that weight off. But then we've got to come up with a better way to maintain than just keeping on the drug. For many, in my view. So that's a great comment. We can't forget lifestyle. I think it was Weight Watchers. They kind of came out and said, "Oh, we kind of got this wrong with the diet, exercise, so we're going to drug." That was my interpretation. I hope not all the way on that.
I don't think that is the way they framed their press release.
That was my interpretation.
Yeah.
Sorry.
Again, what is true is what Weight Watchers obviously has had. Again, it is a reasonably successful lifestyle intervention, but people cycle in and out of Weight Watchers all the time, again, which shows you that, in fact, it fails at some level, right? Mm-hmm. That most people do not adhere to that version for long periods of time. And once so what they did was that they bought a telemedicine company, right, so that they could deliver GLP-1 agonists as part of a therapeutic milieu, right, that is included in with what you can get with Weight Watchers.
So speaking of interventions, there is a question that came in online, and I think this is for you, Dr. Courneya. When you speak about exercise and you advocate for studies that are going to look for exercise, during the treatment period, how are you defining exercise, and what would you recommend in terms of frequency, how much, intensity? What should we be thinking about as exercise as a prescription?
Yeah, exactly, all those parameters, and this is what makes it a bit challenging. So, we can dose exercise just like a drug. How frequently you're going to do it per week, what intensity, are you going to deliver it continuously or as a bolus? So there's all those parameters we can manipulate, and we try and manipulate them in preclinical models and look at some of the biological effects that might help us in the clinical setting. But in the clinical setting, most of our studies compare a particular exercise prescription to nothing at all. And so we don't have really good studies comparing these subtle manipulations among different exercise prescriptions. So we have a general recommendation we give for patients, depending on which outcome they might be trying to improve, but it's mostly driven from a symptom management perspective related to fatigue, quality of life, those types of things. We don't really have an exercise prescription that drives breast cancer tumor growth and spread.
So without that prescription, do you usually recommend, based on what the American Cancer Society recommends, which is 150 minutes, moderate intense exercise per week?
Yeah, that's oftentimes the starting prescription that we work with, yep.
Okay, thank you. And let's take another question from the middle aisle.
Hi, Sherry Shen, Memorial Sloan Kettering. Thank you for the fantastic talks. As you said, it's already clear that obesity is associated with increased risk of various types of cancers as well as worse cancer-specific mortality, but it remains unclear that modulating obesity can improve those outcomes. And these novel weight loss drugs are clearly very potent. So my question is, how can we bring them into the cancer space with considerations like compounded toxicities, that rebound effect, and integration of lifestyle?
Yeah, that's a great question. I know one concern is one of the modes of action of these drugs is gastric emptying, and so that's a concern. Any kind of surgical procedure related to cancer, or even some of the therapeutic interventions in relation to that gastric emptying issue is I've seen concerns about that. So it's going to be challenging. I do think. Yeah, as an obesity reduction strategy, that's probably where it's most of the action is going to be. And we know, as you said, the obesity issue is there as a major risk factor. So I probably in the more preventive mode, but it is intriguing about some of the immune effects, and so I think that's the second avenue that we're going to see kind of really explored. That possibly interacting. I forgot, I was going to ask Kerry if exercise has gotten into the immunotherapy space, and is there evidence that exercise, because it seems like anything that can maybe improve some of the metabolic condition in that tumor microenvironment may really influence particularly the immune therapy side.
No, they're starting to look at that in preclinical models and a couple of clinical studies, but to the question in terms of, when and delivering these drugs, it gets to this combination and sequencing idea, If obesity at the time of diagnosis predicts these outcomes, do you start these drugs while they're on chemotherapy, on radiation therapy? What's the combination toxicity that you've talked about? Or even the interaction with, the chemotherapy or the radiation therapy, endocrine therapy? These combinations and sequencing become tricky to bring in a new treatment into a very busy treatment landscape. So I think that, we really do have to look at those questions before you start figuring how you incorporate that into cancer care.
I see these as really exciting tools with more questions than answers right now, but they have the potential to really have an impact, particularly in the obesity cancer space.
Thank you.
So I think we have time for one more question, and we'll go to the aisle on the right.
Thank you very much. Jennifer Ligabelle, Dana-Farber in Boston. Really wonderful panel, really thought-provoking ideas. And my question was for Dr. Hursting. The data looking at tirzepatide in the breast cancer model, I was just curious, you showed a lot of different circulating biomarkers that were changed with the drug. And I was just curious if you looked at the tumor and sort of what pathways were impacted. You saw the kind of the slowing of tumor growth, and if this was something that was more metabolic or looking at some of the immune-mediated pathways, kind of what was happening in the tumor.
Yeah, that's all we've got for breast so far, so that was right off hot off the press. We've been in endometrial and colon a little bit longer, and so a lot of nice immune modulation and reversing the obesity effects on the immune pathways coming out there. And I will say the effects that we're seeing, we've been including pair feeding groups along with the drug to see how much of the effect is specific to the drug versus a more generalized weight reduction, calorie restriction basically effect. And most of it is the calorie restriction, I will say, across we've looked at breast, colon, and endometrial so far, consistent results, and most of the effects are the reduction in weight. In models where the immune is particularly up front and center, there's this extra effect above the weight that we're seeing, and I think that's the immune modulatory effects. But we need to do a deeper dive. We're just getting kind of rolling on this, but that's what we see so far. I do think the systemic, we're fixing a lot of that obesity-driven systemic dysregulation. So I think I've always thought that was a big driver of the obese effects that are affecting those pathways. So I do think we're fixing that with these drugs. But much like the calorie restriction would do, just people have a hard time doing the calorie restriction.
Mm-hmm. I can attest to that. Yes, it's true.
Wonderful. Well, thanks again. And if you guys would all join me with thanking this wonderful panel for a great session.